So the first one I want to mention is progressive supranuclear palsy. I'll also talk about multiple system atrophy and cortico-basal degeneration. Richardson, Steele and Oślewski described this condition in the late 50s and early 60s. And John Steele is still alive, and when we gave we had a session with the patients talking about PSP, we actually got him on the telephone and he gave an interview from Guam in the Pacific Ocean to the patients and their carers. But his argument is that the condition really should be known as Richardson syndrome or Richardson's disease, because it really took the insights of this guy here, John Richardson, to identify the differences between PSP and CBD that we now recognise. And what are those differences? Well, this is some slides that he very first showed at an American meeting in 1963 describing his, I think it's the second case. This guy died in 1959 at the age of 56 years old. He had 6 years of gait unsteadiness that started in 1953. In the following year, it was noted by Richardson that the thinking had slowed down and the patient complained of difficulty with vision. These are very typical ways of patients describing their symptoms and a typical presentation of PSP. 2 years after he started getting the gait disturbance, he lost expression from his face. And 3 years after onset, he was unable to move his eyes downwards, which is the characteristic diagnostic sign of PSP. In the following years, he started having slurred speech, stiffness in the neck, and pyramidal signs implying that he was weak and had some brisk reflexes. In the year before he died, so 5 or 6 years after presentation, that's when he started getting the slowness of movement. So it's really wrong to say that patients with PSP look like Parkinson's in the first year, because they often don't get much in the way of bradykinesia, slow movement. They'll talk about problems with their eyes, problems with their balance, but their hand movements might not be as slow as someone with Parkinson's disease. They'll often develop mild cognitive problems, which may be evident early on. In this case, it only emerged after about 5 years. Slurred speech is typical and often earlier than this, and the eyes end up becoming completely fixed without being able to move, and typically patients will die from respiratory complications. So this video doesn't transmit very well, but this is video of the original patients that Richardson saw, and demonstrating the problems with the eye movements. Rather than the hunched posture of Parkinson's disease, patients with PSP are upright and extended with the neck backwards usually. The postural reflexes are much more impaired, so balance is much more impaired in patients with PSP, and the tendency to fall over spontaneously and also while moving around is quite high. Patients have very stiff necks, the eyes tend to close over, and they don't tend not to move very much, which is poorly demonstrated in that video. So how do we identify patients with PSP? Well, if every 30 patients that come through the clinic, if most of them have Parkinson's disease, we're going to be right almost all of the time if we say everyone's got Parkinson's disease. Of course, that's not really the way we should be working. We keep an open mind with every patient we see. So I tend to have a look at what sort of symptoms the patients are talking about, or what's been reported about them when they come into the clinic. So the disorder has to be progressive. Of course, PSP doesn't happen just causing one symptom and then disappear. Unfortunately, we don't have any mechanisms for stopping the progression of disease so far. So it has to be a progressive disorder. It has never been reported to occur in anyone under the age of 40. So by definition, if you're 39 or younger, then you don't have PSP. And the reason is there's a few genetic disorders that can emerge from teenage years up until the 30s that look a little bit like PSP. In general, most patients fall within the first year of symptom onset, so they might complain a little bit about slowness of thinking or double vision or difficulty with walking, but compared to Parkinson's disease, people with PSP will almost always fall within the first 1 or 2 years of the condition. So I ask if they've had a fall, and then I look at their eye movements to try and find the diagnostic features of PSP. This might transmit a bit better. I want you to look at the eye movements of this guy with PSP, he's trying to look up and down and left and right. So looking up, he's got to pull the neck backwards to look up. The eyes are very, very slow coming down. They don't even, he's asked to look down to the ground. He just can't generate the movements down there. He's trying to bend his neck. Now, when he keeps his eyes on the camera, his eyes actually do move up there and down there. Okay, so we move his head in space and his eyes do move up and down. So in fact, this is where this terrible name of supranuclear comes from. The nucleus works all right, that is, the eyes can actually move up if you can invoke some head movements, but when you ask the patient to voluntarily look up and down, they can't do it. And that's a supranuclear, that is coming from the brain rather than the brainstem problem, and those connections are lost in PSP. So what other things help support the diagnosis? So far I've only told you they have to be over 39 years of age, fall in the first year, and has to be progressive condition. Well, usually they do have to have some rigidity, often just in the neck, and it's usually less in the arms than in Parkinson's disease. And here's a picture of one of the guys we saw in the video with that rigidity in extension, very severe axial dystonia, pulling the neck backwards, which is typical. One of the other typical clinical features is the patients usually look very surprised. You can see, not so much, he doesn't look very surprised there. So we look at frontalis overactivity. There's often wrinkling of the frontalis muscle, and this is dystonic. It's there all day as they try and keep the eyes open and the head's pulled backwards. So they have this startled expression on their face. Early swallowing problems and speech disturbance is consistent with PSP, much more likely than in Parkinson's disease. And patients will have early cognitive problems. Now, not frank dementia, not amnesia or loss of memory, but just reduced thinking speed. We call it executive dysfunction, difficulty solving problems and thinking about different things at once. Compared to Parkinson's disease, these patients generally have a preserved sense of smell. They don't experience visual hallucinations, and they don't usually have REM behaviour disorder at night time. So these are things on history that I ask patients to try and differentiate the two conditions. The average age of onset is 65 years of age. Most people with Richardson syndrome will die after 7 years, or 50% of people will die before 7 years, 50% afterwards. And the mode of death is usually from a fall where they get a hemorrhage into the brain, or respiratory dysfunction from aspiration and pneumonia. This is what we see under the microscope, an accumulation of an abnormal protein in the brain. This is where we start talking about the engine in my car, and some of you, your eyes will glaze over, but hopefully something will stick and you'll remember it when you see your next patient with PSP. So it's caused by abnormal protein accumulation in several different parts of the brain, predominantly in the basal ganglia, and that's the part of the brain where the movement comes from. So spontaneous movement is slow, static movement like neck posture is exaggerated, and eye movements are reduced. Not everyone with PSP actually has those diagnostic features, and I like to talk about it because it was what my PhD was about. But the reason you guys need to know is that sometimes there'll be people that come through the clinic or through your therapy sessions, and you'll say, but hang on, the patient has normal eye movements and they've got a bit of tremor, and David said that that's Parkinson's disease, not PSP. Well, unfortunately, most people don't go by the textbook, and there's a range of different presentations of this PSP pathology. Most of them don't respond very well to medications, and most of them have a similar mode of death at the end. But in some cases, we can say to the patient, well, you've got the good form of PSP, you're going to live for 12 or 14 years if they ask that question. So normally that gaze palsy that I showed you, the abnormality with the eye movements comes within the first 2 years. Now, if it doesn't, and this happens in about 30% of patients with PSP, they might have a different phenotype or a different type of PSP, and I'll tell you a little bit about them. One is PSP Parkinsonism, where the patients look like Parkinson's disease for the first 2 to 8 years and then develop more classic signs of Richardson syndrome. Another one is pure akinesia with gait freezing, and I'll show you some videos on that. And the last one is cortico-basal syndrome, which we'll spend some time talking about.